Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV and OI respiratory system, and the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day is currently working as a technical specialist CST with iTech India. His past assignments include working with ART Plus Center in Assam, Children's Hospital of Indian Red Cross Society, UNICEF, etc. His key strengths include clinical management, supportive supervision, capacity building, program implementation, harm reduction, mental health, mentoring, and M&E, etc. We welcome you, sir, for today's session and request you to start the session.
Thank you. So today's topic is National Respiratory System, OI. You will find this topic in 4.3, chapter number 4.3 of the National Guideline for HIV Care and Treatment 2021. And this has already been taken under RDLS. So today's topic would be a recapitulation of those RDLS. Now, just a minute. Yes. So I don't know why it is not moving. No, it's moving. Yeah, yes, moving. So today we are going to see the different OIs, respiratory OIs, like the Mycobacterium tuberculosis. But tuberculosis is a big chapter and has also been taken in other sessions. So we'll be covering only some of the features of TB, and along with those points which are missed in earlier, not included in the HIV TB session. Then we'll go through the pneumocystis joveri pneumonia, bacterial pneumonia, MAC, then teleuromycosis, and other pathogen with pulmonary manifestation. So, 2/3 of all the HIV patients can have treatable respiratory infections, and frequent respiratory complaints in PLHIV include cough, dyspnea, pruritic chest pain, either alone or in combination. And HIV-associated respiratory diseases can be of upper respiratory tract infection like sinusitis, bronchitis, and then a lower respiratory tract infection like pneumonias. Now, association of pulmonary tuberculosis, pulmonary infection with CD4 counts in HIV-infected patient. Mycobacterium tuberculosis can happen with any CD4 count, we all know, but it is more common if the CD4 cell count is less than 400 per cubic millimeter in PLHIV. Now, bacterial pneumonia, whenever CD4 goes below 250 in PLHIV, and suppurative lung and sinus diseases, whenever it goes below 100 cells per cubic millimeter. And PCP pneumonia with a CD4 count of less than 200 cells, it is more common. And MAC is more common when the CD4 goes below 100. Similarly, cytomegalovirus infection is also more common in PLHIV whenever CD4 goes below 100 cells per cubic millimeter. Now, coming to Mycobacterium tuberculosis, we know it is the most common cause of death in PLHIV, and it is also most common. The TB in presence of HIV TB in HIV leads to rapid progression of HIV, leading to AIDS, while HIV also gave rise to reduced ability of the immune system to kill the bacteria. And in around 20, the rate of EPTB amongst the PLHIV is almost double than the general population. In general population, it is 20%, while in HIV, the EPTB is 40%. In India, around 5 to 15% of adults with latent tuberculosis infection develop active TB, and 5 to 10% of infected people develop active TB, while it is 16 to 21 times more common in HIV-infected person. And in 2019, India had a total HIV-TB of 71,000. Now, the impact of the disease. On HIV, the impact of HIV on TB, the impact is risk of developing TB becomes more in PLHIV, 3 to 10% develop TB, and HIV-infected TB patients suffer much higher mortality than HIV-negative one. And recurrence of TB, long-term TB, and post-TB mortality among PLHIV are extremely high. On the other hand, inflammatory response to TB bacilli increases HIV replication, leading to rapid progression of HIV to AIDS, and among AIDS, TB is the most common OI. The mortality due to TB in AIDS is very high. Now, manifestation of TB in relation to immune suppression. we know clinical presentation often resembles post-primary tuberculosis in adult type in early phases of HIV immunosuppression, while in the late phase it resembles primary TB. That is, we know in an adult normal people, after the infection is contained by the strong immunity into the Kong focus as a primary complex. But this will not happen in cases of late phase of TB, and it will spread all over. Sputum smear result is mostly positive in early phase of the immunosuppression, but it's mostly negative in case of late phase of immunosuppression. And chest X-ray appearance is similar to the adult normal individual whenever affected with tuberculosis. That is, it shows cavities and upper lobe predilections are more. But in case of late phase of the immune suppression, there is atypical presentation. Often there is infiltrates in the mid or lower lung fields, and in the thoracic lymph nodes are also common, but cavities are very infrequent. Now, diagnosis, as we all know, it is through the ICF at the IRT center using 4 symptoms of tuberculosis screening. So in case of adult, it is just a recapitulation that current cough, fever, weight loss, and night sweat. And in case of children, cough, fever, poor weight gain, and history of contact with the TB case. Now, any of the symptom if present, then we suspect it to be a possible tuberculosis, and we refer the case to for diagnostic purpose towards the CBNet or other appropriate investigations are being done. Now, these are same in case of TB. These are taken from NTP guideline, but for in ART center, what we do, presumptive TB, if there is present of any of the 4 symptoms of TB, then we send the patient directly to the CBNet or TrueNet. And then if it is positive, then there are 3 possibilities. One is rifampicin sensitive, rifampicin negative, rifampicin sensitive, rifampicin resistant, and intermediate. So in case of intermediate, we refer the patient for management of rifampicin resistant. In case of rifampicin resistant, we refer the patient to the DRTB center. And in case of rifampicin sensitive, we label it as confirmed, microbiologically confirmed TB and start treatment in the ART center through the single window service delivery system. And in case of rifampicin intermediate sensitivity, we repeat the CBNet test on second sample, and indeterminate on second sample, we collect fresh sample for liquid culture or LPA. Now, all those suspected tuberculosis cases or presumptive TB should be offered HIV counseling and testing. However, diagnostic workup for TB must not be delayed. So it is the NTP guideline. So it is for those setup where people are diagnosing primarily TB, screening TB, and found presumptive TB, and all those presumptive TB should undergo HIV testing. But in our center, in ART center, they are all HIV patients, so this part doesn't come. Maybe in the index cases, it might come in the caregiver and all. Now, presumptive EPTP. In case of presumptive EPTP, appropriate sample collection is, if possible, then we go for CBNet. And based on CBNet, whether MTB detected or MTB not detected, we start treatment. If it is detected, then it is microbiologically confirmed one. And if the samples are available, if CBNet is not available and sample is available, then we send the sample for liquid culture. And if culture is positive, we can label it as microbiologically confirmed TB. While if culture is negative, we say no TB. Or if there is high clinical suspicion, even if the culture is negative, we can take the help of other diagnostic modalities, and we can diagnose it clinically as TB, and we can start treatment. Otherwise, we'll go for the alternate diagnosis by referring the case to specific department. Now, there are certain tools for microbiological confirmation of TB, like rapid molecular diagnostic test, NAT test, or CBNet test, or TrueNet test. Then this cartridge-based nucleic acid amplification test is very useful because it doesn't need any biosafety cabinet. It is a closed system and performance specific for MTB and sensitivity close to culture. And detection of rifampicin resistance is also done in one go, and provides accurate result within less than 2 hours so that the patient can be started on ATT on the same day. and it has minimum biosafety requirements, and training needs are also less and can be housed in non-conventional laboratories. So these are the usefulness of CBNet. That's why it has been included in the program. And there are other methods like culture methods. It is a solid media, automated liquid culture system, Bactec MGIT 960, Bactec and Alert or Bursa track. Now, Lowenstein-Johnson medium, solid medium, it takes long duration and it is a tedious process, and dedicated manpower, trained manpower are required, and it is difficult to sustain quality. Bactec liquid culture, turnover time is around 8 days, and 99% agreement with rifampicin, 94 with INH and streptomycin, and 91% for ethambutol. And MGIT, that is the Mycobacterium growth indicator tube assay, it is more specific and sensitive than culture, and turnover time is 8 days. So in practice, we send for liquid culture and all. Now, tools for microbiological confirmation of TB, drug sensitivity testing, modified proportionate sensitivity testing for MGIT 960, and economic variant of proportion sensitivity testing 1% using LJ medium. Now, follow-up test for patients on treatment for drug-sensitive TB. We can go for sputum smear microscopy with Zillenser staining or fluorescence staining. NET test cannot be used because they can pick up the dead bacilli in treatment, after treatment, or during follow-up of treatment. So sputum specimens are preferred, and sputum smear microscopy has to be done. So the meaning is that during diagnosis, we depend mostly on CBNet because it is more specific and sensitivity are very high. But in follow-up, to see whether the treatment, how the patient is responding to treatment, we should go for sputum smear microscopy instead of CBNet, because CBNet will pick up the dead dying bacteria and it can give false positive report, while sputum smear microscopy will give the correct report. So in follow-up, we use smear microscopy and not NET. Now, what are the basic principles? The first basic principle is that we go for ICF, intensive case finding, by 4A screening. And if found positive, immediately fast track and refer to the CBNet testing facility, and other appropriate investigations are done. Number two principle is that if the patient with active TB is diagnosed with HIV, the priority is to start TB treatment and then ART. Now, all HIV-TB conflicted persons are to be initiated on ART within 2 weeks of ATT treatment, ATT, regardless of the CD4 count, except for TB meningitis. In case of meningitis, it should be within 1 month to 2 months. Within 2 months, 1 to 2 months, it has to be started in case of TB meningitis. And Cotrimoxazole prophylaxis should be given to all HIV-TB patients. Now, coming to pneumocystitis joveri pneumonia, earlier it was known as pneumocystitis carini pneumonia. Now, PCP is caused by Pneumocystitis joveri, ubiquitous fungus, and use of ART and prophylaxis for PCP have dramatically reduced the number of new cases of PCP. 20 to 30% PCP occurs in AIDS patient, 20 to 40% PCP associated with mortality even after treatment, and 90% PCP occurs when CD4 count is less than 200 cells per cubic millimeter. And 2/3 of healthy children who do not have HIV have antibodies to pneumocystitis joveri by 2 to 4 years of age. Now, clinical manifestation. In adult, dyspnea is the main symptom. This is the key presenting feature, and initially this occurs on exertion, but later it also occurs at rest. Low level of oxygen, that is hypoxemia, can be confirmed with the use of pulse oximeter. However, rapid respiratory rate can compensate for hypoxia. So reasonable oxygen saturation may be shown even in pulse oximeters. And then there is dry cough, tachypnea, often with flaring of nostrils, and temperature may be normal or high, or maybe above 40 degrees centigrade. Chest X-ray characteristically shows a ground glass that is hazy appearance that is more pronounced in the lower lung zone. Intrathoracic lymph nodes are not a radiological feature of pneumocystitis pneumonia. Now, in children, major findings are tachypnea, dyspnea, cyanosis, sudden onset of fever. Chest auscultation is less specific. The intensity of respiratory distress is a more important sign. In chest X-ray, it shows ground glass appearance or reticulonodular granular appearance. In a centrifugal manner, means it starts at the hilum and gradually spreads to the periphery. And rarely, lobar, cavitary, or miliary lesions can also be seen, and pneumothorax or pneumomediastinum may also be seen. Now, how to classify tachypnea in case of children? Less than 2 years, it is 60 respiratory rate 60 per minute. And from 2 months to 12 months, it is 50 per minute. And if it is more than 40 or 40 in children between 1 to 5 years, we call it tachypnea. And for children older than 5 years, 30 breaths per minute is considered as tachypnea. So the diagnosis, it basically depends on clinical presentation, blood test, and chest blood tests, etc. But chest radiographs are not pathognomonic of PCP because the organism can be cultivated routinely. So it is basically on presumptive basis we start treatment. Now, for confirmation, we need histopathologic or cytopathologic demonstration of organism in tissues or in the bronchoalveolar lavage fluid or induced sputum samples for a definitive diagnosis of PCP. But for practical purpose, it is based on clinical presentation and the combination of signs and symptoms and investigation. We start on clinical ground. Now, presumptive diagnosis, presence of clinical symptoms, low CD4 count, below 200 is more diagnostic. Then presence of oral candidiasis, that is compromise of the immune system, severe compromisation of the immune system, and suboptimal prophylaxis in the past. And oxygen saturation can be used to grade the severity, and chest X-ray may support the diagnosis. And a high LDH level is an unfavorable sign and indicates severe PCP. Definitive diagnosis, we need to demonstrate the organism in pulmonary secretions, either by sputum induction with hypertonic saline. The sensitivity is 50 to 80%, and in case of bronchoalveolar lavage, 86 to 97%, and for transbronchial lung biopsy and bronchoalveolar lavage combined, it is 99% sensitive to diagnose the PCP. Now, sputum collection is often difficult. It can be collected by inhalation of hypertonic saline or by nebulization. All material coughed out around 2 to 3 ml is collected and diluted with an equal volume of sterile water. The specimen is liquefied or as such it can be used to prepare smear and staining. It is difficult to induce sputum in children, in which case we may go for bronchoalveolar lavage. Then prophylaxis of PCP. For adults, if the CD4 goes down less than 350 cells per cubic millimeter, or if the patient is having stage 3, WHO stage 3, stage 4 condition, we should start prophylaxis. Now, this is the primary prophylaxis. And for secondary prophylaxis, for all patients who have completed successful treatment of PCP, then we should continue cotrimoxazole prophylaxis up to CD4 cell when it becomes more than 350 cells per cubic millimeter in 2 occasions separated by 6 months. Now, regimen is cotrimoxazole double strength. There is trimethoprim 160 milligram and sulfamethoxazole 800 milligram each day, or 2 single strength tablet daily. Alternatively, if allergic to or intolerant to cotrimoxazole, that is rash, anemia, neutropenia, etc., desensitization may be tried if the reaction is of a lesser degree, like grade 1 or grade 2. But in case of severe hypersensitivity reaction, we should not re-challenge or attempt to desensitize. We should change the regimen to dapsone 100 milligram per day. Now, discontinuation, whenever CD4 goes above more than 350 cells per cubic millimeter on 2 different occasions, separated by 6 months, with an ascending trend of CD4 and devoid of any WHO clinical stage 3 and 4 conditions, then we can stop the prophylaxis. Now, when to start primary prophylaxis? Whenever CD4 falls below 350 cells per cubic millimeter, or if there is WHO clinical stage 3 and 4 condition. Now, timing the initiation of cotrimoxazole in relation to initiating ART. We should start cotrimoxazole first. After starting, start ART after starting cotrimoxazole as soon as the CPT is tolerated and the patient has completed the preparedness phase of counseling. So whenever the patient comes with the presumptive symptoms of TB or in the stage 3, stage 4 condition, we start first cotrimoxazole, and during that time, preparedness counseling goes on, and the patient is also investigated for PCP and all. So first we start cotrimoxazole, and then if there is PCP, we can start the treatment of PCP. Thereafter, we start secondary prophylaxis, and ART to be started after Cotrimoxazole prophylaxis. Now, commencing, I think there may be some confusion, no? Actually, we are talking about preventive therapy, Cotrimoxazole preventive therapy. And here, first, we will have to start Cotrimoxazole therapy. And then when the Cotrimoxazole is tolerated, we should start ART. And commencing secondary prophylaxis for all patients who have completed successful treatment of PCP until CD4 is more than 350 cells per cubic millimeter, at least on 2 occasions separated by 6 months apart. And dose of Cotrimoxazole, we know it is 960 milligram, that is 800 milligram of sulfamethoxazole and 160 milligram of trimethoprim. Cotrimoxazole for pregnant and breastfeeding women, there is no contraindication of Cotrimoxazole in pregnancy or during lactation. Anybody who is qualifying for CPT should get the CPT, that is Cotrimoxazole prophylaxis treatment. Now, patient allergic to sulfur-based medication, we can go for dapsone 100 milligram per day. Cotrimoxazole desensitization can be tried only in grade 1 and grade 2 toxicities, but not in grade 3 and 4. And monitoring, there is no specific laboratory monitoring needed for Cotrimoxazole prophylaxis. And discontinuation of Cotrimoxazole prophylaxis is based on the CD4 count if it is more than 350 cells per cubic millimeter on 2 occasions, separated by 6 months, and with an increasing CD4 trend, and there is no stage 3 or stage 4 condition, then we can stop the Cotrimoxazole prophylaxis. Now, for protocol for Cotrimoxazole desensitization is that we started with the oral suspension of 80 milligram sulfamethoxazole and 16 milligram trimethoprim on the day 1. So it is 2 ml because the strength of the suspension is 40 milligram trimethoprim and 200 milligram sulfamethoxazole per 5 ml. So on the first day 1, we give 2 ml, day 2, 4 ml, then 6 ml, then 8 ml on day 5. Day 4 and day 5 single strength, and on day 6 double strength of CPT is given. Now, prophylaxis of PCP. Indications for CPT prophylaxis in children. All HIV exposed children, infant from 6 weeks of age till the patient is proved to be negative by testing, antibody testing at the age of 18 months. And all HIV infected children up to 5 years, regardless of WHO stage or CD4 percentage or count. And at 5 years, when the clinical or immunological indicators confirm restoration of the immune system for more than 6 months, that is, in a child of more than 5 years of age with a WHO stage 1 or 2 condition and CD4 count of more than 350 cells per cubic millimeter on 2 occasions and not less than 6 months, and should be done at a gap of 6 months. Now, indicate for all HIV infected children more than 5 years of age, whenever there is WHO stage 3 or stage 4 conditions, regardless of CD4, we should start. And if the CD4 falls below 350 cells per cubic millimeter, we should start CPT. And to discontinue, we need the CPT count of more than 350 cells per cubic millimeter on 2 occasions separated by 6 months. And there should not be any stage 1, stage 2 condition. And the trend of CD4 should be a rising trend. And as secondary prophylaxis after completion of the treatment of PCP, in case of less than 5 years of age, we never stop. And more than 5 years of age with a WHO stage 1 or 2 and CD4 count of more than 350 cells per cubic millimeter on 2 occasions and not less than 6 months apart, then we can stop. Dose of Cotrimoxazole for PCP prophylaxis in children is less than 5 kg, 2.5 ml, 5 to 10 kg, 5 ml, 10 to 15 kg, 7.5 ml, and 15 to 22 kg, it is 10 ml. And more than 22 kg, it is 15 ml. Now, management of PCP, moderate to severe, mild to moderate, trimethoprim 15 to 20 milligram, and sulfamethoxazole 75 to 100 milligram per kg, divided into 3 doses. And alternatively, we can start 100 milligram of dapsone plus trimethoprim 5 milligram per kg orally thrice daily. Other alternatives are primaquine 30 milligram orally plus 450 milligram of clindamycin every 6 hours, or atovaquone 750 milligram orally twice daily with food. And for moderate to severe cases, CPT 15 to 20 milligram of trimethoprim per kg per day in every 6 hours, divided into given every 6 hours. And alternative regimens are pentamidine, 4 mg per kg IV, daily infused over 60 minutes, can reduce dose to 3 mg per kg IV daily in the event of toxicities, or primaquine 30 mg orally, plus clindamycin 600 mg IV every 6 hours, or clindamycin 450 mg orally every 6 hours, or 600 mg per oral every 8 hours. Now, adjunctive steroid therapy. What are the indication? If the oxygen saturation goes below 70 millimeter Hg in room air, then we should go for steroid therapy. The dose is day 1 to 5, we should give 40 milligram twice daily in case of adult, and in case of children, 1 milligram per kg per dose twice daily. And for day 6 to day 10, we give 40 milligram of steroid once daily in case of adult, and in case of children, 1 milligram per kg per dose once daily up to 6 to 10 days. From 11 to 21 days, we give 20 milligram of steroid orally in case of adult, and 0.5 milligram per kg per dose for children. This steroid therapy is life-saving. If we are to give based on the criteria, then we should start as early as possible with the treatment of PCP and should continue for full 21 days. We should not stop in between. And duration of treatment is 21 days. Now, high-dose Cotrimoxazole for treatment of PCP in children. So less than 5 kg, we can go for 2.5 ml, that is the prophylactic dose, but 4 times a day. Similarly, for 5 to 9.9 kg, 5 ml 4 times a day. 10 to 14.9 kg, that is 10 to less than 15 kg, 7.5 ml 4 times a day. And 15 to 21.9 kg, 10 ml 4 times a day. And more than 22 kg, 15 ml 4 times a day. And for giving 3 times a day, the strength is 4 ml, 7 ml, 10 ml, and 15 ml in this age group. And in more than 22 kilo, we can give 2 tablets of single strength tablet 3 times a day. Now, coming to bacterial pneumonia. So the most common pulmonary manifestation we know first is TB, PCP, and the pneumonia. Incidence of bacterial pneumonia is 0.8 to 2 per 100 year. Incidence of pneumonia increases by 6 times in untreated HIV patients. So risk factors for pneumonia and PLHIV are low CD4 count, especially when it is below 100 cells per cubic millimeter, lack of ART or non-adherent on ART, tobacco, alcohol, or injection drug use, and chronic viral hepatitis. And risk factor for older people is COPD, malignancy, renal insufficiency, congestive heart failure. And for children, the risk factors are underlying pulmonary disease, bronchiectasis, chronic lung disease. Now, clinical manifestation in adult, acute onset, 3 to 5 days of symptoms, including fever, chill, rigor, chest pain, or pleurisy, cough, productive in nature, and purulent sputum, and dyspnea. In children, fever, cough, tachypnea, and chest indrawing. This chest indrawing is very, very important. We should not miss it. And then in adult, presence of fever, tachycardia, and or hypotension can be indicators of sepsis, while in children, stridor in a calm child can be associated with bacteremia. And children may frequently be not able to drink or breastfeed. Persistent vomiting can be there, convulsions can be there. And poor sensorium, lethargic or unconscious, and stridor in a calm child signifies associated bacteremia. And tachypnea and decreased arterial oxygen saturation indicate moderate to severe pneumonia in case of adult. But in children, we know the grading of tachypnea. If it is more than 60 per minute in infant less than 2 months of age, or 50 breath per minute in infant to 12 months of age, and more than 40 per minute in children aged 1 to 5 years, and more than 30 in children older than 5 years, then it is considered as tachypnea. Now, classification of pneumonia in children. CLHIV. Child less than 5 years age with the cough and or difficulty in breathing. So if there is only cough and cold and no pneumonia, we provide home care advice. But if there is fast breathing and or chest indrawing, then this shows it is a pneumonia, and we start oral amoxicillin and home care advice. And general signs of serious illness like tachypnea and all, oxygen saturation, decrease of oxygen saturation, etc., severe pneumonia or very severe disease, first dose of antibiotic is given and referred immediately to the facility for injectable antibiotics and supportive therapy. Now, recurrent bacterial pneumonia and signs of severity. Severe recurrent bacterial pneumonia, current episode plus one or more in the previous 6 months. So within 6 months, if a patient develops CLHIV or a PLHIV develop pneumonia twice in the last 6 months, then it is called as recurrent pneumonia. And respiratory rate should be more than 30 in case of adult, and hypoxia, there is oxygen saturation less than 90%. And in children less than 15 years, there would be cough with fast breathing, chest indrawing, nasal flaring, wheezing, and grunting. So for diagnosis, we need microscopy, culture of common pathogens, chest X-ray, WBC, AFB staining, and TB cultures. Differentiating features between PCP and bacterial pneumonia, it is very important. So clinically, we'll find CD4 less than 200 cells per cubic millimeter in case of PCP, we are likely to find. And in pneumonia, any CD4 count is possible to have a pneumonia. Now, symptom-wise, in PCP, we have non-productive cough, but in pneumonia, we have high fever, productive cough, purulent sputum, chest pain. And clinicals, other symptoms like symptom starts, duration of the symptom is around 2 to 4 weeks in case of PCP, while it is typically 3 to 5 days in pneumonia. And occasionally, inspiratory dry crepitation can be found in the case of PCP, while there are focal lung signs on auscultation, palpation, chest X-ray, etc. WC count varies in case of PCP, while it is elevated in case of pneumonia, and mostly it is neutrophilic leukocytosis. Now, in chest X-ray, distribution is normal or diffuse in case of PCP. So it is important to find that a normal chest X-ray is also possible in case of PCP, or there will be diffuse ground glass appearance, centrifugal in nature, that it will start in the center and gradually spread to the periphery. But in case of pneumonia, we'll find lobar, focal, unilateral, or segmental. And pattern in X-ray is reticular or granular in case of PCP, but in pneumonia, it will be consolidation, so there will be air space. And in pleural effusion is very rare in PCP, but 1/3 of patient of pneumonia can have pleural effusion. And there is possibility of cyst in case of PCP around 15 to 20%, but it is very rare in pneumonia. So management of bacterial pneumonia, general consideration are that treatment duration is for 5 to 7 days. The patient should be febrile for 48 to 72 hours and should be clinically stable before discontinuation of the antimicrobial therapy. Longer duration of antibiotics is often required when severe pneumonia or bacteremia is present, and particularly if due to Streptococcus pneumoniae or complicated Staphylococcus aureus infection. Switch from IV to oral therapy. A switch can be considered for patients who have improved clinically and can swallow and tolerate oral medication, and there are no GI symptom. A GI function is intact, then we can shift the patient from IV antibiotic to oral antibiotic. The oral regimen in non-severe cases are beta-lactams like high-dose amoxicillin with or without clavulanate plus a macrolide, azithromycin or clarithromycin. In children, oral amoxicillin 40 mg per kg per dose twice daily for 5 days. Alternatives are cefpodoxime, cefuroxime, or respiratory fluoroquinolones like levofloxacin, moxifloxacin. And especially for patients with penicillin allergies, we can go for it. And in children, alternatives are beta-lactam, cotrimoxazole, and azithromycin. For hospitalized patients with non-severe cases, an IV beta-lactam plus a macrolide, azithromycin or clarithromycin. Preferred beta-lactams are ceftriaxone, cefotaxime, ampicillin, sulbactam, and IV respiratory fluoroquinolones like levofloxacin or moxifloxacin, and especially for patients with penicillin allergies. In children, ampicillin 50 mg per kg or benzyl penicillin 50,000 units per kg IM or IV every 6 hours for at least 5 days, along with gentamicin 7.5 mg per kg IM or IV once a day for at least 5 days. An IV beta-lactam plus doxycycline can be an alternative. IV penicillin may be used for confirmed pneumococcal pneumonia. So for using IV penicillin, we should confirm that it is a pneumococcal pneumonia, then only we should use penicillin, IV penicillin. Now, patients with severe pneumonia and IV beta-lactam plus IV azithromycin or an IV beta-lactam plus IV fluoroquinolones. Preferred beta-lactams are ceftriaxone, cefotaxime, ampicillin, sulbactam. Now, alternative therapy for penicillin allergic patients is carbapenems IV plus an IV respiratory fluoroquinolones like moxifloxacin or levofloxacin. Now, patient at risk of Pseudomonas pneumonia, an IV anti-pneumococcal anti-Pseudomonal beta-lactam plus ciprofloxacin IV or levofloxacin IV. Preferred beta-lactams are piperacillin tazobactam, cefepime, imipenem, or meropenem. Alternative therapies are IV anti-pneumococcal and anti-Pseudomonal beta-lactam plus an IV aminoglycoside plus IV azithromycin. And the other alternative is IV anti-pneumococcal anti-Pseudomonal beta-lactam plus an IV aminoglycoside plus an IV anti-pneumococcal fluoroquinolones like moxifloxacin or levofloxacin. Patient at risk for MRSA, MRSA, that is methicillin-resistant Staphylococcus aureus pneumonia, we should use vancomycin IV or linezolid, IV or oral. Now, MAC, Mycobacterium avium complex disease. In PLHIV with advanced HIV disease, that means CD4 less than 200, MAC usually causes disseminated disease. The mode of MAC transmission is thought to be through inhalation, ingestion, or inoculation of MAC bacteria. Then typically it occurs in PLHIV with CD4 count below 50 cells per cubic millimeter. The patient may present with fever, night sweat, chills, weight loss, muscle wasting, abdominal pain, tiredness, and maybe enlargement of the liver, spleen, and lymph nodes. A confirmed diagnosis of disseminated MAC should be based on compatible clinical signs and symptoms, coupled with the isolation of MAC from culture of blood or lymph node, bone marrow, or other tissues or body fluids. Routine prophylaxis for MAC is not recommended in India. And management of MAC is preferred therapy, at least 2 drugs to prevent emergence of resistance. And these are clarithromycin plus ethambutol, 500 milligram clarithromycin twice daily, ethambutol 15 milligram per kg daily, or azithromycin 500 to 600 milligram plus ethambutol 15 milligram daily when drug interaction or intolerance precludes the use of clarithromycin. So preferred molecule is clarithromycin plus ethambutol. Or if we cannot tolerate this clarithromycin or there are some drug-drug interaction, then we can go for azithromycin plus ethambutol. And other alternatives are rifabutin 300 milligram per hour daily with fluoroquinolones as for example, levofloxacin, moxifloxacin daily. Now, criteria for discontinuing therapy: completed at least 12 months of therapy, and there should not be any sign and symptoms of MAC, and have sustained CD4 count more than 100 cells per cubic millimeter in response to ART, and when the CD4 is done for more than 6 months. So, and the trend of the CD4 should be increasing trend. Now, telleromycosis, previously it was known as penicilliosis. Now it is known as telleromycosis. Telleromycosis is caused by a thermally dimorphic fungus, Telleromyces marfani. Earlier it was called Penicillium marnefi. Then geographically restricted to Southeast Asia and Northeast India. It is subacute illness characterized by fever, weight loss, hepatosplenomegaly, lymphadenopathy, respiratory and GI abnormalities can also be there, and skin lesion. The central necrotic papule with umbilication appearing on the face, trunk, and extremities occur in 40 to 70% of patient. And we need, so this is the feature of cutaneous manifestation of telleromycosis. So clinical manifestation, the chest symptoms would be cough, shortness of breath. GI symptom would be diarrhea, abdominal pain, hepatosplenomegaly with intra-abdominal lymphadenopathy causing abdominal distensions and pain. And central nervous system involvement gives rise to meningoencephalitis and is a rare manifestation and has a rapid disease course with high mortality. Others like anemia, thrombocytopenia due to bone marrow infiltration, elevation of aminotransferases is common with serum AST or over ALT ratio approximately 2. Now, diagnosis should be considered in all patients with HIV and whoever shows signs and symptoms of the signs and symptoms that we have discussed earlier. And the presumptive diagnosis is based on microscopic examination of GIMSA, right or Gomori methanamine silver stain, samples of skin lesion scraping, lymph node aspirate, bone marrow aspirate, or tissue sections. Now, definitive diagnosis. For definitive diagnosis, we need histopathologic demonstration of the organism in biopsy specimens. Antigen detection and PCR-based methods are promising rapid diagnostics currently under evaluation. Now, prevention and management. Preferred therapy is induction therapy with liposomal amphotericin B, 3 to 5 milligram per kg per day IV for 2 weeks, followed by consolidation therapy with itraconazole 200 milligram twice daily for 10 weeks, followed by maintenance therapy or secondary prophylaxis with itraconazole 200 milligram oral daily. Alternative therapies are induction with the deoxycholate amphotericin 0.6 milligram per kg per day IV for 2 weeks, followed by itraconazole 200 milligram twice daily for 10 weeks, followed by maintenance therapy with the itraconazole 200 milligram once daily. And for criteria for discontinuation is CD4 counts more than 200 cells per cubic millimeter for more than 6 months in response to ART. And other pathogens with pulmonary manifestations like histoplasmosis. Clinical manifestations are progressive disseminated histoplasmosis presents with fever, fatigue, weight loss, and hepatosplenomegaly. Pulmonary manifestations are cough, chest pain, and dyspnea. And CNS manifestations are headache, seizures, focal neurological deficit, and changes in mental status. And GI manifestations are diarrhea, fever, abdominal pain, and weight loss. And diagnosis is based on CSF finding are lymphocytic pleocytosis, then elevated protein and low glucose. Fungal stains are usually negative, and CSF cultures are positive in a minority of cases. Histoplasma capsulatum can be cultured from blood using the lysis centrifugation technique, bone marrow, respiratory secretions, or from samples from other involved site in more than 85% of PLHIV. And disseminated histoplasmosis, the organism requires several weeks to grow. But the sample we can have, but it needs several weeks to grow, so it takes time. Detection of histoplasma antigen in blood or urine is a sensitive method for rapid diagnosis of disseminated and acute pulmonary histoplasmosis, but is insensitive for chronic form of pulmonary infection. Now, management: moderate to severe disseminated disease, induction therapy with liposomal amphotericin B, 3 milligram per kg daily for 2 weeks or until clinically improved, or deoxycholate amphotericin B, 0.7 to 1 milligram per kg IV daily for 2 weeks, and maintenance therapy with itraconazole 200 milligram thrice daily for 3 days, then 200 milligram twice daily. And for less severe disseminated disease, induction and maintenance can be done with itraconazole 200 milligram thrice daily for 3 days, and then 200 milligram twice daily. Duration of therapy must be 12 months. Nocardiosis. Clinical manifestation: the most common symptoms at presentation are chronic cough, chest pain, dyspnea, and hemoptysis. Pulmonary nocardiosis is a chronic disease which can rarely have an acute course as well. It rarely has skin involvement with subcutaneous ulcerated nodules, and the disseminated form has nervous system involvement with symptoms like headache, altered mental status, and ataxia. Diagnosis is chest radiographic findings of pulmonary nocardiosis in advanced HIV disease include alveolar infiltration, cavitation, pleural effusion, and reticulonodular pattern. And in computer tomography, findings are chest shows multiple nodules in almost all patients and cavitation in majority of patients. Bronchial washings are shown to be useful for isolation of nocardia. Nocardia may take several days to weeks to grow in culture, and sputum smears with quinine acid-fast stain reveals acid-fast branching filaments of nocardia. So on the right-hand side, we have the acid-fast branching filaments of nocardia on the lower picture, and the upper picture, we have the X-ray findings of nocardiosis, pulmonary manifestation of nocardiosis. Then management is treatment for 6 months with cotrimoxazole plus amikacin. Now, aspergillosis, there are 3 clinical syndromes associated with the depending on the presentation of the case. First one is allergic bronchopulmonary aspergillosis. Second is aspergillosis mycetoma or fungal ball, invasive aspergillosis. This occurs in PLHIV mostly and presents with high fever, pulmonary consolidation, hematogenous dissemination. Symptoms include fever, dyspnea, cough, chest pain, and hemoptysis. Diagnosis is chest radiographic finding include thick-walled cavities, most commonly in the upper lobe. Culture of organism can also be done if possible. So we find cavities here also. So we need to differentiate it from tuberculosis. Then management. liposomal amphotericin B or the combination of caspofungin and voriconazole should be considered. COVID-19, we all are experienced nowadays after this COVID. Hopefully, all of us have given duty in COVID, so we know. So, what are the different manifestations? COVID can involve any of the system. So, renal, it can give rise to acute kidney injury or acute tubular necrosis. In liver, it can give rise to increase AST, ALT, and increase in bilirubin, decrease in albumin. Pulmonary manifestations are pneumonia, acute respiratory distress syndrome, respiratory failure. Neurological symptoms are headache, neuropathy, encephalopathy, cerebrovascular dizziness. Then ocular are epiphora, conjunctivitis, chemosis. Dermatological manifestation are erythematous rash, widespread urticaria, chickenpox-like vesicles. And in cardiovascular, symptoms are arrhythmias, myocarditis, pericarditis, acute coronary syndrome, heart failure. And for gastrointestinal symptoms, it is diarrhea, nausea, vomiting, abdominal pain, ageusia, that is, cannot smell. Then COVID-19 in PLHIV. In milder cases, there is upper respiratory tract symptoms and or fever without shortness of breath or hypoxia. In moderate disease, we have dyspnea or evidence of lower respiratory disease with the oxygen saturation of 92, 93, less than 93% on room air and respiratory rate more than 24 per minute. In case of severe disease, we have tachypnea, hypoxemia, and lung infiltrates on imaging with a SpO2 of less than 90% on ambient air. So COVID-19 and PLHIV. Risk factors for severe disease or mortality among PLHIV with COVID-19 is age more than 60 years, presence of cardiovascular disease, hypertension and coronary artery disease, presence of diabetes mellitus and other immunocompromised state, chronic lung or kidney or liver disease, cerebrovascular disease, and obesity. So this much for today. So if you have any question, please unmute yourself and ask the question.
Thank you,
can
sir.
also use the chat box.
Participants are requested, please unmute your mic and ask the question. There is no question in the chat box, sir. I will quickly run feedback poll.
Okay, you go for the feedback.
Participants are requested, please attempt that feedback poll form. Thank you all for your participation. Sir, can we conclude the session now?
Yes, please.
Okay.